Hello everyone, this is Dr. Gaurav. This video is rated medical student difficulty, and if you stay by the end of the video, you should be able to understand pharmacokinetics, pharmacodynamics, bioavailability, volume of distribution, clearance, first order kinetics, elimination kinetics, steady state, loading dose calculation, and a special nerd corner. So Pharmacokinetics is basically what body does to the drug. It will absorb, it will distribute, it will metabolize, and then eliminate the drug. So absorption depends upon the route of administration. Like drugs which are administered IV do not need to be absorbed, so they will be 100% bioavailable in your blood vessels, in your intravascular space, and hence in your plasma. Distribution of the drug basically involves this concept of bioavailability. I will explain about this later. Metabolism is the sum total of all chemical reactions in the body. Metabolism here in this context is first pass metabolism and then second pass metabolism. First pass metabolism is done by the liver mainly, and liver, some drugs are prodrugs, and the liver activates and metabolizes one chemical into another. Then this active compound acts in your body, and then there is elimination. Elimination is done by kidneys, lungs, and liver. So the kidneys will basically excrete the drug, and some monoclonal antibodies are excreted through lungs, and some drugs are metabolized by most of the drugs are metabolized by liver. There are certain and cytochrome P450 is involved, but we'll talk about that in future videos. Then there is pharmacodynamics. Pharmacodynamics is basically what drug does to the body. Okay, so it involves mechanism of action and side effects. This you'll be learning about in pharm. So yeah, so bioavailability. Bioavailability is the fraction of drug reaching into systemic circulation. Like I said, in IV it is 100% because it directly putting the drug through veins into your body, so it's 100%. In oral it will always be less because the absorption will be less. Like if you should not take levothyroxine with tea, or because it decreases absorption. Yeah, you should this is the practical application of absorption concept, and so this is the graph. On the y-axis we have plasma concentration of a drug, and on x-axis we have time. So this is area under curve IV. Okay, so it starts from 100% because IV there is no need for absorption, and in this is area under curve for oral. This starts slowly because drug reaches into your GI tract, then it is slowly absorbed, then it reaches to a certain maximum, then it decreases again. Okay, so bioavailability is basically we're comparing the oral bioavailability to oral ratio of the oral medication to the IV medication. Okay, so if you divide this portion by this, you'll get the bioavailability. So I theoretically it can be like 3/4. Okay, if you take a 3-gram drug, and if you take 4-gram drug orally, then only 3 gram will reach your blood vessels in your digestive will be absorbed by your digestive tract. And there is if you take directly through IV, it all whole amount of will be inside your blood vessel. So yeah, then there is this concept of bioavailability is in ratio. Okay, 3 and 4 is like 0.75. Then there is this concept of volume of distribution. It is a theoretical concept. Okay, suppose its blood volume is 5 liters, but volume of distribution can be 50 liters. Okay, so theoretical volume occupied by the total amount of drug relative to its plasma concentration. So uh, how is this 50 liters? Okay, because this is theoretical, volume of distribution is basically the amount of drug in body divided by plasma drug concentration. And volume of distribution, you can understand it like this, like some drugs are lipophilic, and some means that they are more soluble in lipids, so they will go into the fat of your body and redistribute there, then they will slowly leak into your blood vessel as well. So, and there is this concept of apparent volume of distribution. So if when the drugs are primarily plasma protein bound, they are the apparent volume of distribution can be changed by liver and kidney for those drugs. Okay, because uh, liver they are the liver can increase the metabolism, liver can affect the metabolism, and kidneys can eliminate. So this concept is basically theoretical. Don't be confused by it. It becomes more clear later on. So volume of distribution, some drugs have low, some have medium, some have high. Okay, so it depends upon the drugs which have low volume of distribution, they are primarily in intravascular compartment. Like I said, drugs with high volume of distribution are usually in fatty tissues. Okay, like in CNS drugs, the CNS has myelin sheath and the lipids, and that's why the drugs will sort of go into those that. Why is this important? This is important because those drugs will slowly come back into the bloodstream as well. So we're trying to sort of titrate, adjust at the doses if needed. So drugs with low volume of distribution are in primarily in intravascular compartment, and we can do hemodialysis for these drugs, like lithium. Okay, for lithium toxicity, I mean, I'm not saying that lithium has low volume of distribution, but just leave that for now. But some drugs which are primarily in intravascular compartment, they we can use hemodialysis to eliminate them if there is need. Okay, these are primarily large charged and plasma protein bound molecules, and medium volume of distribution drugs are primarily in extracellular fluid. Okay, these are less hydrophilic molecules. Hydrophilic means water loving. And then there are drugs more which have more volume of distribution. Okay, the CNS drugs like phenytoin. Okay, then there is this concept of clearance. Clearance is simply volume of plasma cleared of drug per unit time. Okay, clearance depends upon the drug. Drugs have their primary modes of elimination. Like I said, monoclonal antibodies by um, your lungs, most of the drugs by the liver, and some of them by a lot of them by kidney. So clearance is rate of elimination divided by plasma drug concentration. Okay, and then clearance, a formula for clearance is there is this another relationship called volume clearance is equal to volume of distribution into elimination constant. And volume of distribution, I hope you understood. And this elimination constant is basically, just for the sake of understand it like that, basic base level function of whatever is eliminating. We've made that constant. Okay. And then there is this concept of half-life. Half-life is basically time in which the drug becomes half during elimination. Like you took 50 mg drug, then it will become 25 mg. Okay. So how this will become half? Because some of it will be metabolized, then excreted. Okay. Then there is steady state. Steady state is drug in equals drug out. Then the drug is in steady state concentration, steady state in the body. Steady state is basically a dynamic equilibrium. Okay, don't be fazed by these terms. It's just simply the rate is constant. Okay, rate of in is equal to rate of excretion or metabolism. So, and then there is this formula of half-life, 0.7 into volume of distribution upon clearance. You don't have to go into the details of it, you can remember it, and this is derived, but I'll explain it later on, maybe in another video. Then there is elimination kinetics. Okay, so first order elimination means constant fraction of the drug is eliminated per unit in some time. Okay, and zero order kinetics means the constant amount will be eliminated. So these things are different, so and important to understand, because there are drugs like phenytoin, ethanol, and salicylates like your aspirin. They will be eliminated constantly per unit time. So your dosing for these drugs will be different, and your dosing for first order kinetics drugs will be different. Okay. uh, and some most of the drugs are eliminated by first order kinetics. Okay. And to reach a steady state, it takes 4 to 5 half-lives. Mind you, don't think that the steady state will depend on uh, the frequency or dose. It depends upon half-life. This is very important to understand. Okay. Like half-life of elimination is like this. First half-life your drug will be after first half-life you will be 50%, then after two half-lives 50% of 50, which is 25, then 50% of 25, which is 12.5. So some basic numericals can be there, like a person took 200 mg drug, then after 3 half-lives how much of it will be left. So after 3 half-lives 25 mg will be left. Okay, simply. And then there is this concept of loading dose. Okay, loading dose and maintenance dose. Okay. uh, Loading dose is basically target plasma concentration which we want to achieve into volume of distribution upon F, which is bioavailability. And this is basically intuitive. Okay, and you can, so basically the target drug concentration you want into uh, depending upon how much of it is distributed into fat, because we are concerned with plasma and bloodstream volume, and upon bioavailability, because biology, like I told you, may be 0.75, and some of the drug will just not go into the system. So this is loading dose. And for maintenance dose, basically you have to consider clearance and time between doses. Okay, so maintenance dose is target plasma concentration into clearance into tau, which is time or frequency between doses upon bioavailability. Okay. And like I said, time to steady state depends upon half-life and not on the dose or dosing frequency. It takes 4 to 5 half-lives for steady state normally, and in 3.3 half-lives there is 90% steady state is usually achieved. Then there is this nerd corner. Thank you if you reached this end of the video and you sat through my this explanation. So why do you think molecules decide to go from their high concentration to their low concentration? My question is that if there are 4 molecules here, why do they decide to go into to the other side? Okay, why don't they stay here? I will give this answer in the next video. Like, comment, suggest, subscribe. If you like it, let me know if you want me to make more such videos. This is Dr. Gaurav signing off.